Imagine flinching in pain and craving more of it at the exact same moment. That's the paradox we're unraveling today. And it's not just about kink. I'm Dr. Julian. And if you've ever wondered why your body's most vulnerable spot can feel like ground zero for both agony and euphoria, you're not alone. This is the question flooding my DMs. And most clinics won't touch it with a 10-foot speculum. So we're going there. By the end of this video, you'll know 3 things. 1. Why your testicles are wired like a faulty alarm system. 2. The neuroscience that makes a slap feel like a serotonin spike. 3. Exactly how to explore this safely without ending up in my oar. And before we go any further, if you think this is just a fringe fetish, the data on endocannabinoids might surprise you. Let's start with the obvious. Why would anyone voluntarily seek out pain in their most prized anatomical assets? It seems biologically counterintuitive. To understand that, we first need to understand why a rogue soccer ball to the groin drops men to the fetal position faster than any punch to the jaw. Here's the anatomy nobody taught you in health class. Your testicles didn't start downstairs. Early in development, they were parked up near your kidneys, tucked inside your abdomen. As you grew, they migrated downward, dragging their original nerve supply with them. That's why a hit to the groin doesn't just hurt there. It radiates into your gut, triggers nausea, makes you feel like you've been stabbed in the stomach. Evolution basically hardwired your pelvis to your panic center. Your scrotum is a thin bag. No fat, no muscle armor. It's designed that way because sperm production needs a temperature, about 2 degrees below core body heat. But there's another layer to this. If those organs are exquisitely sensitive, you're more likely to protect them. From a Darwinian standpoint, testicular pain is a feature, not a bug. It kept your ancestors alive long enough to reproduce. So, how does the brain flip that switch? Turn an SOS signal into a pleasure cruise? It turns out your brain doesn't have separate inboxes for pain and pleasure. They route through the same neural switchboard. Functional MRI studies show that both painful and pleasurable stimuli light up the nucleus accumbens and the ventral tegmental area. The real estate dopamine calls home. But here's where it gets wild. The translation from ouch to oh depends heavily on context. Factor 1, anticipation. If you choose the stimulus and expect it to feel good, your brain pre-releases dopamine. You've already decided this is reward, not threat. That neural filter literally dampens the pain signal before it reaches full volume. Pain and pleasure are roommates in the brain. They share the same furniture. Factor 2, endogenous opioids. Researchers studying BDSM practitioners found that during impact play, the brain floods with beta endorphins and endocannabinoids. These are your body's homemade morphine. They don't just numb, they elevate. They produce a runner's high, a sense of floating euphoria. Your brain literally self-medicates the sting into a signal that says, more of that, please. And that's before we even touch oxytocin. Factor 3, bonding chemistry. When you engage in intense, consensual, trust-based impact, your pituitary gland releases oxytocin and vasopressin. These are the molecules of attachment, the same chemicals that spike when a mother holds her newborn, or when couples stare into each other's eyes. The pain becomes a shared language. Factor 4, the surrender dynamic. For someone in the receiving role, handing over control of their most vulnerable anatomy to a trusted partner can trigger profound psychological release. It's the opposite of weakness. It's an active choice to be vulnerable. For the person delivering the sensation, the reward isn't in the impact itself. It's in the trust being placed in their hands. Factor 5, the thrill-seeker gene. Some nervous systems are calibrated higher. You don't just tolerate intensity. You crave it. This isn't just personality. It's biology. Research shows people who regularly engage in consensual pain play often have higher baseline pain thresholds and variations in their endocannabinoid receptor density. Their hardware is literally built different. So now that we understand the why, let's talk about the what. What does this actually look like in practice? Most people imagine whips and chains. Reality is usually much quieter. On the gentle end of the spectrum, we're talking about sensation play that many couples don't even label. Light squeezing, fingertips dragging across the scrotum, warm massage, cool metal, gentle stretch. These activities carry near-zero medical risk. They're about novelty, not pain. As you move into moderate intensity, you encounter firmer compression, open-handed impact with controlled force, or tools like soft silicone paddles or leather straps, designed for uniform surface contact. Some people use weighted stretchers or rings that create a sensation of fullness or gentle elongation. Chastity devices, when correctly fitted, fall into this category. They restrict, they remind, but they don't wound. It's the far end of the spectrum, where I, as a surgeon, start to hold my breath. Intense impact with focused tools. Hot wax, electrical stim, or devices that apply high pressure to a pinpoint area. These move into advanced skill territory. If you're curious about that zone, you should be learning from the kink community, not a YouTube video. And honestly, most people never leave that gentle to moderate range, which is exactly where I want you to stay. Because when you leave that zone, you enter the injury zone. Let's distinguish between normal aftermath and emergency. After a session, it's normal to feel a mild, dull ache that fades within minutes. Maybe some transient pinkness. By morning, everything should look and feel like baseline. If the pain gets louder instead of quieter, your body is screaming. Don't mute it. Red flags. Sharp, stabbing pain that amplifies instead of subsides. Swelling that progresses, not plateaus. Skin that turns dusky, purple, or blotchy. Inability to walk or stand upright without guarding. Now, I need to give you the short list of emergencies that require immediate surgical evaluation. These are rare, but if they happen, you don't drive yourself. You get someone else to drive you, or you call an ambulance. Number 1, testicular rupture. This is a tear in the tunica albuginea, the fibrous white capsule that encases the testicle. You'll know because pain will be immediate and severe, and the scrotum will begin to swell like a water balloon. This requires surgery to preserve the testicle. Number 2, hemodocele. This is active bleeding into the scrotal sac. Blood accumulates, creating a tense, heavy, discolored mass. It can compress the testicle and cut off its blood supply. Surgical drainage is often necessary. Number 3, testicular torsion. This is when the spermatic cord, the cable carrying blood and nerves, twists on itself, strangling the testicle. You'll feel sudden, severe pain on one side, possibly nausea, and the affected testicle may sit higher or at an odd angle. The clock for salvage is about 6 hours. After that, tissue death begins. Beyond the acute emergencies, there's the quieter risk. Fertility. Your testicles produce sperm on a strict temperature-controlled schedule. Repeated blunt trauma, especially when it's significant enough to cause swelling or bruising, can temporarily halt production. If trauma is frequent and cumulative, that pause can extend. Chronic inflammation can scar delicate seminiferous tubules. If biological fatherhood is part of your future, this matters. So, if you're going to proceed, and that is your choice to make, here is my non-negotiable safety checklist. 1. Negotiate before clothes come off. Boundaries aren't mood killers. They're the foundation of trust. Establish what is absolutely off the table. Choose a safe word that is short, distinct, and impossible to misinterpret. Also establish a nonverbal signal. Dropping an object, snapping fingers, a specific hand shape, in case speech becomes difficult. 2. Educate before you execute. Watch tutorials from established BDSM educators. Start with bare hands before you introduce tools. Learn the difference between surface impact and thuddy impact. Understand that the scrotum is mobile. Force that lands on a moving target distributes differently than force on a fixed one. 3. Communicate in real time. This isn't check-in when you're done. This is constant feedback. More pressure. Less. To the left. Stop. Good. The brain cannot read minds. 4. Never leave a bound person alone. If someone is restrained, gagged, hooded, or otherwise unable to move or speak freely. They are in a position of absolute vulnerability. You stay in the room. You stay alert. 5. Ischemia is the enemy. Any device that applies continuous pressure, rings, stretchers, tight ties, must be removed at minimum every 20 minutes. Tissues need oxygen. Prolonged compression doesn't just hurt. It kills cells. 6. Inspect afterward. Look at the scrotum in good light. It should be symmetric. Color should be even. Any lump, any hardness, any uneven warmth should be monitored closely and evaluated by a professional if it doesn't resolve. 7. Stay sober. Alcohol and THC blunt pain perception and impair judgment. Pain is a messenger. If you anesthetize the messenger, you won't hear the warning. I also want to address chastity devices specifically, because they're common and often misunderstood. Fit is everything. A base ring that's too tight can abrade skin or obstruct venous return. One that's too loose allows chafing and unintended escape. If you ask my preference, silicone or adjustable plastic devices carry lower risk than solid steel. And regardless of material, removal for cleaning and skin inspection should happen daily. Here's the part one cannot overstate. If something goes wrong, please come in. I know the shame barrier is real. Patients have told me they waited days because they didn't want to explain how the injury happened. Let me make this absolutely clear. I have removed objects from orifices you cannot imagine. I have treated injuries from scenarios that sound like fiction. I do not care how it happened. I care that it happened. And I care about fixing it. You are protected by HIPAA. Your sexual practices are your private medical history. No one, not your employer, not your family, not your partner, will know what you discuss with me, unless you authorize it. Delaying care because of embarrassment is the only preventable complication. Don't let shame cost you an organ. So, here's where we land. Ball busting, cock and ball torture, CBT, whatever label you use, exists on a continuum of adult sexual expression. It is not inherently pathological. It is not a diagnosis. When practiced with informed consent, risk awareness, and mutual respect, it is a valid form of intimacy for those who choose it. But it carries real biological weight. Your testicles are not just sensation sponges. They are endocrine factories. They produce your testosterone. They manufacture your sperm. They are resilient, but they are not indestructible. Repetitive trauma, even when it doesn't send you to the ER, can cumulatively affect function. You deserve to know that. You also deserve to make your own choices. My job isn't to ban behavior. It's to educate you, so you can risk manage effectively. If you found this useful, please hit like. It tells the algorithm that men's health education matters, even when the topic makes people uncomfortable. And subscribe to Dr. Julian, so you don't miss the video I'm publishing next week on something I've never seen covered honestly. Penile fractures, and why they sound like popcorn. Until then, protect what produces you.